Hi, I'd like to thank the organizers for asking me to talk today. I'm going to be talking about a subject that's been the center of all of our lives for this past year, COVID-19, and in particular, its relationship to kidney disease and to our patients who are treated with chronic dialysis. I want to cut to the chase first because there are a couple of really important points that I want to make right at the top. Number one is that our dialysis patients are a remarkably vulnerable population. In some locations around the world, if you're a dialysis patient and you have to go to the hospital because you have COVID-19, 1 out of 3 or 1 out of 4 of the time, you will not survive the illness and will not be able to return to dialysis. That's a remarkably high mortality rate in many locations around the world. And the opportunity of a vaccine that can change those data is incredibly important. Here in January of 2021, the American Society of Nephrology and other professional and patient groups are working hard to see if we can get dialysis patients closer to the top of the list of priorities to get vaccinated. And particularly if you are a practicing nurse or a practicing physician caring for dialysis patients, it is really important to help patients see that the potential risk of getting vaccine is tiny compared to the risk of getting COVID-19. And the personal touch of talking directly to patients so that they really understand that and understand that we really think it's safest for them to get this vaccine is really critically important. Well, okay, so with that introduction, let's go to my first slide. An epidemiologist, an ICU doctor, and a scientist walk into a bar. Just kidding, they know better. This disease has been a remarkably destructive disease, and understanding its epidemiology and how to prevent the spread of the disease has been central to the success of caring for our patients. Dialysis patients are particularly at high risk of acquiring COVID-19 for several reasons. First of all, the comorbidities that so many of our patients have, diabetes, obesity, hypertension, cardiovascular disease, are all the same comorbidities that put people at high risk for COVID-19 and its complications. Our patients are often frail, they're older, and they frequently have some impairment to their immune state. So all of these mean that if they get diabetes, if they get COVID-19, the likelihood of complication and death is substantially higher than it is for other people who don't have these same conditions. In addition to that, patients treated in-center cannot socially distance. 3 times a week they come for treatments. They often are less than 2 meters from their adjacent patient group. They have frequent exposure to patients and staff, and they have to often participate in transportation to and from the dialysis unit 3 times a week that puts them in touch with other individuals who could transmit the disease. In one very interesting study early on in the pandemic out of West London Dialysis, a little over 1,500 dialysis patients were studied, and of that group, 300 or almost 20% developed COVID-19. And when the epidemiology of that was examined, number one, it was more likely for you to get infection if you were in center compared to home dialysis. Second, it was clear that there was clustering in specific dialysis units and shifts, strongly suggesting that spread happened within the dialysis unit. There was also a high rate of nursing staff illness. And when this unit put into place the measures that we all now do of aggressive personal protective equipment, universal masking, screening of patients ahead of time before they come in, isolating patients who are known to have the disease or are patients under investigation. When all those things are done, These measures clearly reduced transmission. Ever since this particular study was done in the United States and other places where these many stringent actions were taken to prevent the spread of infection, it looks like it's extremely rare for patients to acquire the infection in the dialysis unit, a big change from the West London experience. We know that hemodialysis patients who become infected with COVID-19 have higher morbidity and mortality. These two studies that were done just a few months ago, really 6-7 months ago, showed that in Spain and China, if you were sick enough to need to come into the hospital and you were a dialysis patient, that 30% of those patients died. In a more recent study, not shown here, out of New York, likewise, that number was somewhere in the range of 20 or 25%. So we know that if you're sick enough to be in the hospital and you, with COVID-19 and you're on chronic or maintenance dialysis, that the mortality and the morbidity are very high. When EDTA looked at some of the European experience, it similarly showed that among the 28-day case fatality rate among dialysis patients, overall was about 25%. Patients who did not need to be admitted to the hospital had a case fatality rate of only 5%, but if you required hospitalization, 1/3 of patients did not survive the illness. And if you look among patients who required intensive care unit admission, over half of those maintenance dialysis patients did not survive. And so here are some important lessons from early in this pandemic that we learned. Number one is we always are sure to tell our patients not to be afraid to come to the dialysis unit. It can be a fearful thing to know that there are other people that can't socially distance there. But our patients must understand, and we must reinforce, that they have to come, obviously, to do these life-saving therapies. We tell patients to call ahead if you have a fever or cough or symptoms that suggest that you might be infected. Protect yourself at home. Use face covering, social distancing, and hand hygiene. And remember that even though we're nearly a year into this pandemic, these still remain the major ways of preventing spread of infection. We tell our patients and our staff, if you're sick, don't just tough it out at home. Don't just think, I'm going to get through this. If you get sick, call your doctor. And if you're having increasing illness, come to the hospital. These days, many people are getting pulse oximeters that they actually can use at home. And particularly if you develop a cough or sneeze or have symptoms of COVID-19, it's really valuable to check pulse oximetry. And if oxygen saturation starts to fall, to immediately come to the hospital. Lessons for the hemodialysis facility. Number one is a big issue is transportation. Anticipate the troubles of transmitting infection during transportation and educate not only our patients, but our drivers and others in transportation to use those methods to prevent infection. We've learned that we must segregate proven COVID-19 patients and patients under investigation from all others, preferably on shifts or separate facilities that are treating only COVID-19 or PUI patients. If none of those are possible, then taking care of those patients at the end of the line or in a separate area of the dialysis facility with a designated staff. We've been telling everyone all along that screening of staff and patients at every shift with those critical questions about fever, symptoms, exposure to the virus is important. Recently, there's been some question about whether that really is as helpful as we thought it was. So many of our staff and patients have asymptomatic infection, and transmission seems to be so low in the dialysis facilities, now that we're taking all these careful precautions, that it no longer is so clear, at least to me, that those screenings are effective in making a difference in outcomes. We don't want patients sitting next to one another in waiting rooms. Facilities have learned the incredible importance of making mental health resources available to patients and to staff. This has been such a trying time, and many patients have really the need to talk with mental health professionals. And then finally, we tell hemodialysis facilities to prepare for the long haul. We're in the long haul now. Staff illness, staff shortages, staff health, all are key issues that we all must deal with. And appropriate use of PPE has to be continued and enforced. I want to say a word about peritoneal dialysis. First, because home patients that are treated with peritoneal dialysis are clearly at an advantage because they can socially distance and they do have a lower incidence of acquiring infection. But as you see from this small study that was published in the midst of 2020, of patients who were sick enough to be hospitalized with COVID-19 on PD, there still was a high morbidity and mortality. Now, these numbers are obviously very small, and this needs confirmation, but this is the cautionary tale that PD is great for preventing infection with social distancing, but if you get sick and you're on peritoneal dialysis, the risk is still there. The Canadian Society of Nephrology made some recommendations that I think are important for these home peritoneal dialysis patients. Number one is that sometimes elective surgeries are stopped in hospitals when the COVID burden gets so high. We've talked about the importance of continuing PD catheter placement as an emergency procedure, not elective, even in those overburdened hospitals. Home training, they say, should be preferentially offered for the obvious reason of protection of patients at home. Patients are asked to keep a supply, at least a 2-week supply of all dialysis supplies on hand at home at all times, and to report signs and symptoms of infection immediately and assure that anyone around them, including staff that they come in contact with, are using appropriate PPE. There was a time early in the pandemic where delivery of product to homes was an issue because delivery personnel were reluctant to go into the homes of potentially infected people, and patients were reluctant to have them come. But those glitches have been nicely ironed out with good safety protocols that are now being used for all home deliveries. The Canadian Society specifically recommends delaying routine visits and procedures and use of telehealth, which has been a very valuable tool in this pandemic, and particularly to delay the changing of transfer sets, peritoneal dialysis transfer sets, for up to 6 to 9 months. It's routine changing is not needed in the midst of the danger of a pandemic. Next. So let me say a few words about acute kidney injury. What happens that we've learned about, that when this virus strikes, causes multi-system disease and causes acute kidney injury and acute kidney failure. First, the very earliest studies that came out at the beginning of 2020 from China showed that proteinuria and hematuria were present in almost 40% of COVID-19 patients on admission. These are patients with no known previous kidney disease, and that indeed reduced glomerular filtration was present in about 20% of COVID-19 patients who were admitted. So it was clear from the very beginning that the kidney is one of the targets of infection with COVID-19. CT scans of the kidneys showed reduced density, suggesting edema and inflammation of the kidney. There have been a series now of autopsy and biopsy studies that I want to touch on to really emphasize that acute tubular injury is the main mechanism of acute kidney failure in patients with COVID-related kidney disease. Even though there have been many other potential sources, and I'll show you some of the data to support that. So first, the degree of acute tubular injury is actually less on autopsy studies than has been predicted by the stage of acute kidney injury, suggesting that the hemodynamic factors really do play a role. The hemodynamic factors are the usual ones of reduced renal perfusion because of hypotension, systemic illness, systemic infection. So acute tubular injury is important, but so are the hemodynamic factors. Early on in the pandemic, it was found that ICU patients very frequently developed AKI as they were treated with ventilators to support their failing lungs. And it's very possible that aggressive early use of ventilators reduces cardiac output and renal perfusion, and that may be one of the reasons why acute kidney injury was so common early in the pandemic. That has not been the case in more recent months. Some studies have shown viral nucleocapsid protein in the kidneys and COVID-2 antigen in the tubules. But most of the studies do not show any evidence of virus in the kidneys themselves. Some studies have had viral-like inclusions, but those have been questioned as not specific and not necessarily representing virus at all. Collapsing focal and segmental glomerulosclerosis, that glomerular disease, has been reported in kidney biopsies, but is rare. The main injuries appear to be hemodynamic and acute tubular injury. On the next couple of slides, I just want to go through some of the findings that the autopsy studies have shown. If you look at panel A, you see some autolysis where you really can't see the tubules very well. The tubular cells are no longer visible. And so it's hard to see from this whether what the tubular injury really is. Nonetheless, on this slide, you still can see the glomerulosclerosis of that one remaining glomerulus there, and some arteriosclerosis in the upper left-hand corner. Slide B shows glomerulus with mild changes of diabetic glomerulosclerosis with nodules, typical of diabetes, nothing to do with COVID-19. Now in C, it's very interesting. In slide C, you see a glomerulus with red blood cell congestion and intracapillary fibrin thrombosis. And if you look down at D, you see a big fibrin thrombus sitting inside the lumen of an artery. Thrombosis is a significant problem, a problem that caused not only kidney, but perhaps other tissue injury in people with this acute COVID-19, and difficulty often in treating patients with continuous renal replacement therapies or dialysis because the dialysis filters clot frequently. So thrombosis and clotting is a significant problem. In E and F, you see microscopic thrombosis, and then you see a hypertensive nephrosclerotic artery. All of those, the underlying conditions of patients more prone to develop complications. On the next slide, you will see the specific tubular injuries that the autopsies have shown in this disease. A is a pretty normal-looking glomerulus, but if you look from B down to E, you will see some acute tubular injury with luminal ectasia, vacuolization, and eventually loss of the brush borders, until in E, you see severe acute tubular injury. This is the injury that most commonly characterized the pathology of patients with SARS CoV-2 infection. And so, as you see here, there are many potential mechanisms of injury. The one, as it turns out, that's most important is tubular injury, but because it is relatively modest, even with severe AKI, it shows that there really is good potential for renal recovery in those patients, as many patients indeed did recover. A word about ACE2 receptors. ACE2 receptors appear to be a mode of entry for this virus into cells. It's highly expressed in the mouth and tongue, the very places that the virus is spread. It's also highly expressed in the lower lungs on type 1 and 2 alveolar epithelial cells, the source, the location of injury to the lungs. But it's also expressed in the kidney, the heart, the gut, and blood vessels, all known targets of infection. And so it is very possible that this is the mechanism that the virus uses to enter these cells and cause multisystem disease. Now, Dr. Shannon Novostad from the CDC did a really nice survey in May of 2020, after the first wave of infections around the country, looking at the effect of this infection on patients hospitalized with either no previous known kidney disease or chronic kidney disease not requiring dialysis. And here she showed what her findings were. If you see the number of the 4,700 hospitalized patients with, of the 15,154 patients that were hospitalized with COVID-19 at the time of this study, 4,700 had acute kidney injury. In other words, of all people hospitalized with COVID-19, 31% had some evidence of acute kidney injury. The range across different cohorts was between 19% of patients or up to 69% of patients who had this acute kidney injury. If you look at intensive care unit patients, acute kidney injury was seen, as you see here, in 55% of those patients, with a range across the cohorts of between 32% and 100%. If you look at the need for renal replacement therapy in hospitalized patients, again, these are people hospitalized with COVID-19, it was about 6% overall of those who needed dialysis or CRRT, with a range across the cohorts of between 5% and 15%. And if you look in the intensive care unit at the need for RRT, it was between 11% and 51%. So acute kidney injury and acute kidney injury severe enough to need renal replacement therapy is a common finding in this disease. We had an opportunity to look in New York City at the time of its big pandemic to see how it handled the huge influx of patients to hospitals. This is a very meaningful lesson now in early 2021, when so many locations now feel that they have become filled and maybe even overwhelmed. So what happened in New York City? This showed data that we collected in a week in mid-April of 2020, looking at 7 large hospital systems in New York City. The first line shows the number of ICU beds that were there before the pandemic. And on the second line, the number of ICU beds in the mid-pandemic in April. And what you see is that in all of these facilities, they increased the number of ICU beds that were available. And overall, there was nearly a doubling of ICU beds that were made available. So an additional several thousand of ICU beds created in operating rooms, created in radiology suites, created in previously unused hospital space, created in separate buildings that are now repurposed. New York City really stepped up with a remarkable increase in ICU capacity. If you look at that time in April of the ICU beds that were occupied by COVID patients, it ranged from 91% from 57% to 100%. So COVID was virtually completely occupying the ICU at that time. And the number of those ICU patients with COVID that required dialysis or CRRT was between 23% and 65%. Huge amount of needed renal replacement therapy. Also, many systems were fearful that they would run out of dialysate solutions. They were burning through up to 5 times the usual supply of fluids, cartridges, and other supplies. There was also remarkable staffing shortages, obviously because staff became ill or had contacts and were isolating, and remaining technicians, nurses, physicians were working double time and even triple time in order to take care of these very sick patients. It was remarkably heroic and challenging to figure out how to do that. Even though there was a fear that enough fluid would not be transported, the dialysis companies that make the CRRT fluids and dialysate fluids stepped up to the plate, found ways to get enough fluid, and so that virtually no systems suffered from absence of dialysis fluid. As you see here, the variation in the use of CRRT fluid varied between 30 and 70 liters per patient per day. And teams were remarkably creative in seeking alternative renal replacement therapies by reducing the volume of fluid, using intermittent rather than continuous treatments so that one machine would be used for 2 patients or even 3 patients by intermittently removing one from treatment and placing the other patient on. Also, standard intermittent dialysis was used and very successfully used, so you don't need to use CRRT for many patients with acute kidney injury from COVID-19. Sustained low efficiency dialysis was used, and acute peritoneal dialysis was used in many patients at several of these settings. Dr. McCricky from Montefiore shared these data with us that showed the increasing nursing staffing for one-to-one dialysis treatments that were needed. Before the pandemic, you have the numbers here for hemodialysis and acute PD. And in the midst of the pandemic, there was a 2 to 3-fold increase in the staffing needs to care for these patients. In the final analysis, New York did remarkably well by adapting to these needs, by increasing ICU capacity, by staff that fortunately worked incredibly hard and came in to help those in New York. Virtually all patients who needed renal replacement therapy got it and got it successfully. So where are we now? Well, you guys know this as well as I do. Right now, PPE has not been a major issue. There have been some shortages at some places. There are still some hospitals that are, for example, reprocessing N95 masks and using them again. But by and large, there is now sufficient PPE around the country. Hospital beds have been filling and are filled. ICU beds have been filling and are filled. And yet the need to do what happened in New York, to double the number of ICU beds, hasn't really happened in most places. ICU utilization appears lower than in March and April, and it might be because younger patients are now being hospitalized with COVID-19, or perhaps some of the treatments really have made a difference. AKI and renal replacement therapy does appear somewhat less prevalent than in the first wave of this. However, staffing remains a substantial challenge. I want to say a quick word about patients returning from the hospital when they have had COVID-19 and have survived it and come back into the dialysis unit. The CDC originally gave us two ways of assuring that those patients were safe for return. One was by doing serial PCR measurements to make sure there was no more virus in those patients. The second was a time-based method that said if it was 10 days since patients were infected and they were completely asymptomatic, that there was evidence that they did not have any further viable virus and could come back into the unit. And if they were very sick and were immunosuppressed, then after 20 days, it would be fine to come back in. The first method of looking at the PCR testing is really a problem because many patients continue to be positive for PCR testing for weeks and sometimes even months after infection. The meaning of that positivity is not clear. Could this be just viral particles that this very sensitive test picks up, but no viable transmittable virus? We don't have a clear answer to that question quite as yet. And so right now we are using the time-based criteria shown here that says if patients coming back are asymptomatic and have been at least 10 days from their infection if they were healthy and 20 days from their infection if they were immunosuppressed or very sick, then it's safe to bring them back into the dialysis facility. And then finally, I want to say a message about what has been called long haulers. Again, as I'm sure everyone here knows, patients have had systemic symptoms for months after infection. And there have been a whole variety of described symptoms, including multiple neurologic symptoms like fatigue, fuzzy heads, short-term memory loss, tremors, fever and night sweats, GI symptoms, bruising, arrhythmias, particularly tachy arrhythmias that patients have described, and then sometimes some pleuritic type symptoms. The etiology of several of those might be clear. People have had lung injury. You can understand why they might have pleuritic pain, but many of the others are not well understood. Long haulers have been studied by centers in some of the larger cities that specialize in caring for long haulers. And I anticipate that this year we will be getting some information about the etiology of many of these symptoms. And so then just the last slide, if I may, to just summarize, dialysis patients are at particular risk for COVID-19, and we should be working hard to encourage our patients to get vaccinated, encourage our staff to get vaccinated, because the risk of the vaccine, if there is some, is clearly far less for our patients than the risk of COVID-19. Home dialysis appears to be advantageous. We need some regulatory help because AKI patients treated with PD and discharged from the hospital can't come directly to PD units and get paid for those treatments. So the ASN and others are working on that now. Dialysis patients may suffer neurologic, cardiac, GI, liver, and particularly clotting sequelae of COVID-19. What do we know about the long haulers? How long will they have symptoms? What can we do about that? We have a lot to learn for that. And we need clarity. What's the meaning of persistently positive PCR in dialysis patients? And can we be sure that those immunosuppressed patients really are safe to come back to our units in 10 or 20 days after their infection? I want to thank you for listening, and I want to thank the organizers for inviting me to have this discussion.